Hola a todos, buenas tardes. Bienvenidos a esta mesa del Congreso de la Sociedad Española de Nefrología de este año 2021. Es una mesa que promete ser muy interesante, muy prometedora, en el que se va a hablar de actualización en la vasculitis. Empezaremos con la primera charla de la doctora Eva Rodríguez García, del Hospital del Mar en Barcelona, que nos hablará del estado actual de marcadores de actividad en la vasculitis ANCA. Posteriormente hablará la doctora Gemma Fernández Juárez del Hospital Fundación Alcorcón en Madrid sobre la implicación de la vía alternativa del complemento en las vasculitis ANCA. Luego nos presentará el doctor David Jane de la Universidad de Cambridge sobre la actualización en los tratamientos de la vasculitis ANCA y finalmente concluirá esta mesa el doctor Charles Pusey del Imperial College of London sobre el rol de la plasmaferesis en el tratamiento de la vasculitis ANCA en el momento actual. Tengo el placer de comoderar esta mesa con la doctora Elena Marco, de la Fundación Cusber.
Muchas gracias, doctor Sebaca. Es un placer para mí estar comoderando este simposio también contigo. Como ha dicho mi compañero, se emitirán las 4 charlas pregrabadas de forma secuencial y después tendremos 30 minutos para la discusión. Os agradeceríamos que para poder preparar las preguntas y agilizar la discusión vayáis enviando las preguntas desde la primera ponencia, no os esperéis al final de todas las ponencias y haced constar a quién va dirigida cada pregunta. Recordad que para hacer la pregunta debéis clicar en el lápiz que está en la parte superior derecha de la pantalla. Muchas gracias y demos paso a las comunicaciones.
Hola, buenas tardes. Antes de empezar, quisiera agradecer a la Sociedad Española de Nefrología que me haya invitado a formar parte de este simposio de actualización en vasculitis. Voy a hablaros de marcadores de actividad de vasculitis ANCA y vamos a seguir este índice. En la última década todos hemos sido testigos de grandes avances en el conocimiento de las vasculitis asociadas a ANCA, especialmente en 2 campos, en la fisiopatología y en la terapia inmunosupresora. Pero desde la descripción de las vasculitis en la década de los 40 no ha habido avances significativos en el desarrollo ni de herramientas ni de diagnóstico ni de monitorización de actividad. Seguimos utilizando la creatinina sérica, la hematuria, la titulación de los ANCA y en nuestro caso y como prueba gold estándar la biopsia renal. Pero estas herramientas no nos dan una información fiable al 100% ni nos dan información sobre actividad. Por ello necesitamos un biomarcador. ¿Para qué exactamente? Porque necesitamos un diagnóstico seguro de vasculitis ANCA. En nuestro caso tenemos que ser capaces de predecir brotes renales y tenemos que saber si hay actividad vasculítica o no. En los últimos años está emergiendo con fuerza el concepto de enfermedad de smoldering disease, ¿no? Enfermedad latente. Son aquellos pacientes que no hacen un brote de vasculitis renal grave, pero tienen una actividad mantenida que hace que su función renal evolucione hacia la enfermedad renal crónica terminal. Tenemos además la necesidad de un biomarcador que nos ayude en la terapia inmunosupresora más adecuada para nuestros pacientes. Tenemos que evitar la sobre o la infrainmunosupresión y es muy importante que dispongamos de información pronóstica. Fijaros a la derecha hay un gráfico sobre el desarrollo temporal de un biomarcador. De los que os voy a hablar más adelante están todos en la fase de verificación y de validación. No tenemos todavía ninguno en la fase de utilidad clínica. Vamos a hablar primero de los biomarcadores clásicos, los anticuerpos anticitoplasma de neutrófilo y los antígenos mieloperoxidasa y proteinasa 3. Todos sabemos el valor diagnóstico de los ANCA en un contexto adecuado clínico está bien establecido y conocemos el importante papel que tienen en la fisiopatología de la enfermedad. Pero su papel como marcador de actividad es controvertido. En esta tabla que tenéis aquí, Thomason recogió en un metaanálisis todos los estudios sobre los ANCA y su correlación con la actividad. Y en el mejor de los casos lo que demostró fue una muy débil correlación. El estudio de Kema describe que la monitorización de los ANCA es útil en pacientes con afectación renal. Junto con estudios posteriores, estos datos sugieren que la monitorización de los ANCA podría ser útil en fenotipos de vasculitis con capilaritis, es decir, en aquellos pacientes que tienen glomerulonephritis y hemorragia alveolar, pero no sería tan útil en pacientes con enfermedad granulomatosa. Lo que podemos prácticamente asegurar es que la remisión de la enfermedad suele ser paralela a la disminución o negativización de la titulación de los ANCA. Sabemos que el brote es mínimo, el riesgo de brote es mínimo si los ANCA son persistentemente negativos y que si tras la terapia de inducción alcanzamos la seronegatividad, esta se asocia a periodos largos libres de enfermedad. Estos datos han sido apoyados además por datos prospectivos procedentes de las cohortes de ensayos clínicos. A día de hoy podemos asegurar también que no se aconseja que tomemos decisiones sobre el tratamiento basándonos exclusivamente en cambios en la titulación de ANCAs. Respecto al antígeno mieloperoxidasa, sus datos son como poco controvertidos. Se ha descrito que el aumento de su titulación tras haber alcanzado la seronegatividad se correlaciona con brote sistémico, pero no queda muy claro su correlación con el brote renal. Los datos sobre la proteinasa 3 proceden de la cohorte RAVE y lo que describen es que es muy poco específico para predecir brote, pero identifican 3 posibles causas. Nos dicen que eso se puede deber a los métodos de detección. Es más, cuando se monitorizaban los pacientes utilizando métodos de ELISA de captura directa, sí que se demostró correlación con actividad. Lo mismo pasa con el fenotipo. En aquellos pacientes que tenían un fenotipo de capilaritis, sí que hubo correlación con los niveles de proteinasa 3. Y por último, como todos sabemos ya, en los pacientes tratados con rituximab, la proteinasa 3 sí que marca correlación de actividad, a diferencia de aquellos pacientes tratados con ciclofosfamida y azatriopina. Ahondando en el problema de las pruebas diagnósticas, recordemos que los documentos de consenso nos dicen que tenemos que hacer técnicas de screening mediante inmunofluorescencia indirecta y confirmar estos resultados mediante ensayos enzimáticos. Pero es muy probable que haya que reconsiderarlas. En los últimos tiempos se han descrito tasas de novo de glomerulonefritis necrotizante pauciinmune ANCA negativo que pueden alcanzar un 30%. Pero esto puede ser así porque sean falsos negativos, porque estemos detectando, por ejemplo, otro autoanticuerpo. Esto ya se ha descrito en pacientes en los que se detecta antiplasminógeno tisular y anti-LAMP, ambos muy relacionados con la fisiopatología de los ANCA y se coexpresan hasta en un 25% de los pacientes con la mieloperoxidasa y la proteinasa 3. Lo mismo pasaría con el anticuerpo antimoesina, que es un homólogo de la mieloperoxidasa. Es posible que nuestras pruebas de detección no sean capaces de detectar otro epítope. La mayoría de los detectan ANCAs IgG, pero sabemos además que existen ya series de pacientes que tienen un ANCA IgA o incluso un ANCA IgM. Y por último, una explicación podría ser que nuestras técnicas no detectaran los ANCA porque están debajo del límite de la detección. Y aquí nos faltaría acabar de elucidar cuál es el papel de la ceruloplasmina, que como sabemos es un inhibidor natural del ANCA que puede enmascarar la detección. Siguiendo con el problema de las pruebas diagnósticas, de manera muy reciente hemos publicado los resultados de la cohorte de vasculitis ANCA del grupo de Glosse, en el que diseñamos un estudio retrospectivo con el objetivo de determinar si la monitorización de los niveles o los títulos de mieloperoxidasa y proteinasa 3 predecían brote renal en pacientes que ya hubieran tenido un brote de glomerulonefritis necrotizante pauciinmune previo y que estuvieran en remisión completa en ese momento. Hemos reclutado a pacientes en los que la titulación de mieloperoxidasa se hiciera utilizando tecnología multiplex y de la de proteinasa 3, técnicas de inmunoensayo por quimioluminiscencia. Como veis, reclutamos 113 pacientes con 54 brotes renales y, como era de esperar en nuestra muestra, la mayoría de los pacientes fueron p-ANCA mieloperoxidasa positivo. Si nos fijamos en los resultados, los títulos de mieloperoxidasa 3 meses antes del brote renal ya eran significativamente más elevados en aquellos pacientes que iban a padecer un brote renal. De hecho, fuimos capaces de establecer un punto de corte en una titulación de 8.3, que, como veis por la curva ROC, es capaz de predecir con una muy alta sensibilidad el brote renal. Además, calculamos una variable que llamamos delta de MPO, que era una manera de evaluar cómo se movían estas titulaciones los 6 meses antes del brote. Fijaros que en aquellos pacientes que iban a tener un brote de glomerulonephritis se empiezan a elevar los títulos a los 6 meses aproximadamente. De hecho, determinamos que una elevación superior a 3,7 puntos era capaz de predecir brote renal. Respecto a los resultados de la proteinasa 3, si os fijáis, a los 3 meses o en el delta de la proteinasa 3, aquellos pacientes que no iban a tener brote tenían niveles absolutamente negativos de mieloperoxidasa, de proteinasa 3, y el hecho de positivizarse ya predecía al 100% un brote renal. Vamos a pasar a hablar ahora de los nuevos biomarcadores. Estos han sido identificados en los procesos fisiopatológicos de la vasculitis ANCA, especialmente en 2 procesos, en el cebado de los neutrófilos y en la activación de los monocitos. El cebado de los neutrófilos es uno de los procesos iniciales de la vía inflamatoria que va a dar lugar al daño vasculítico. En este proceso, los neutrófilos activados hacen que las micropartículas de mieloperoxidasa y proteinasa 3 emigren a la superficie de los neutrófilos y se expresen, dando lugar a toda la activación que va a involucrar proteínas de la vía alternativa del complemento, células B, citoquinas y las micropartículas de los neutrófilos. No voy a hablar de las proteínas de la vía alternativa del complemento porque detrás de mí lo va a hacer magistralmente la doctora Fernández. Los datos que tenemos sobre las células B proceden de los datos de las grandes cohortes de los ensayos clínicos. La cohorte rituximab nos sugirió que el brote de vasculitis podía venir acompañado de una reconstitución de los linfos CD19 después del tratamiento con rituximab, pero estos datos fueron absolutamente negados por los resultados de las cohortes Mainrinsan 1 y 2. Los resultados de la cohorte RAVE nos dijeron que tampoco los niveles de CD19 predecían brote vasculítico. Por ello, el interés se movió hacia una subpoblación específica de las células CD19, que son las células B reguladoras. Sabemos a día de hoy, por datos de la cohorte RAVE, que las células B reguladoras tampoco se correlacionan con el brote de actividad. Respecto a las citoquinas, se han identificado 3 citoquinas en el suero de los pacientes procedentes de la cohorte RAVE 6 meses después de entrar en remisión. Se les extrajo suero y se buscaron marcadores diferentes y de las citoquinas, como veis por las curvas que tenéis a vuestra derecha, se identificaron estos 3 candidatos capaces de predecir brote renal que están ahora mismo en estudio de utilidad clínica. Vamos a hablar ahora de las micropartículas de los neutrófilos. Fijaros que estas micropartículas que liberan los neutrófilos activados llevan partes de proteinasa 3 y mieloperoxidasa y se ha descrito su elevación en el suero de niños con vasculitis ANCA, pero también en el suero de niños con vasculitis ANCA negativa. Y fijaros que los niveles disminuyen cuando la vasculitis está inactiva. Su utilidad clínica está por confirmar, igual que su utilidad en adultos. Si pasamos ahora a la activación por monocitos, en este proceso se han identificado 3 biomarcadores que posiblemente son los más prometedores, especialmente los 2 primeros, cuya determinación además es urinaria, ¿no? Ni siquiera tenemos que pinchar al paciente. Vamos a empezar hablando de la proteína 1 quimiotáctica de los monocitos, también conocida como el CCL2. Lo que se ha descrito en los pacientes con vasculitis ANCA activa y persistente es que los niveles urinarios de MCP1 son muy elevados y fijaros que disminuyen tras alcanzar la remisión. Además, algunos estudios han descrito una correlación con la infiltración de macrófagos en el glomérulo mediante técnicas de inmunohistoquímica. Si hablamos ahora de los NETs, recordar que la netosis consiste en la liberación de las fibras de cromatina desde los neutrófilos activados. La formación de NETs mediada por ANCA en los capilares glomerulares induce un daño endotelial grave y trombosis. Esto aparece en otras enfermedades y de hecho se está estudiando como objetivo terapéutico en un ensayo clínico en lupus hoy en día. A nivel de vasculitis ANCA se ha descrito depósito a nivel renal y elevación sérico y está siendo estudiando su potencial como biomarcador. Por último, vamos a hablar del que seguramente en la actualidad es el más prometedor, que es el CD163 soluble. Esta sustancia se expresa en monocitos y en macrófagos y es un marcador subrogado de actividad inflamatoria. Fijaros en el esquema de este estudio recientemente publicado, en el que los autores lo que hicieron fueron determinar las cantidades urinarias que había de CD163. Fijaros que ellos describen que están significativamente elevados en pacientes con vasculitis ANCA y los niveles disminuyen cuando se inactivan. Posiblemente es mucho más interesante que son capaces de correlacionar los niveles urinarios de CD163 con lesiones histológicas. Fijaros que lo pueden correlacionar, aunque la correlación no es muy fuerte, con lesiones como la necrosis fibrinoide y además con las hemilunas celulares. A este modelo diagnóstico de reconocer rebrotes de vasculitis ANCA, ellos le dan una sensibilidad de un 94% con una especificidad de un 91%. Podríamos concluir esta sesión diciendo que los ANCA podrían ser marcadores de actividad útiles en situaciones concretas, especialmente en los fenotipos de capilaritis y en aquellos pacientes que se van a tratar o que se han tratado con rituximab. Es necesario mejorar las técnicas diagnósticas utilizadas en la detección y cuantificación de los ANCA, amiloperoxidasa y proteinasa 3 para dotarlos de una mayor especificidad. Actualmente parece que hemos identificado algunos marcadores urinarios prometedores, incluso se habla de alcanzar la biopsia líquida. Por último, es necesario investigar sobre nuevos biomarcadores que nos permitan mejorar el seguimiento de nuestros pacientes y nos ayuden a indicar el tratamiento inmunosupresor más efectivo en cada caso. Muchas gracias por su atención.
Hola a todos, soy Gemma Fernández del Hospital Universitario Fundación Alcorcón y en los próximos 15 minutos les hablaré de la implicación de la vía alternativa del complemento en la vasculitis ANCA. Hasta hace no demasiado tiempo todos pensábamos que la activación de los neutrófilos por los anticuerpos ANCA eran los únicos o el único mecanismo patogénico en esta enfermedad. Por otro lado, la ausencia de depósitos de inmunoglobulinas y de complemento en las biopsias renales, de hecho todos lo conocemos como glomerulonephritis autoinmune, apoyaban esta única vía patogénica sin que en ningún momento dudásemos de ella. Sin embargo, en la última década, algunos estudios experimentales en animales, que les contaré a continuación, y algunos estudios de inmunohistoquímica y serológicos en humanos han puesto en jaque esta idea y actualmente se piensa que la vía alternativa del complemento juega un papel esencial y necesario para el desarrollo de la enfermedad. De hecho, ya se ha publicado un ensayo clínico en el que un bloqueante del complemento, el abacopal, que es un bloqueante del receptor C5A, ha demostrado tener algún papel en el tratamiento de esta enfermedad. Este es el modelo clásico, el modelo animal que reproduce la vasculitis MPO, no existe modelo para el PR3, en el que un ratón previamente inmunizado se le inyecta IgG-MPO y en pocas semanas desarrolla el modelo completo de vasculitis ANCA. Unos años más tarde, sin embargo, en el año 2007 se observó que cuando este mismo ratón se trataba previamente con veneno de cobra, que es un inhibidor del complemento, de todas las vías del complemento, el modelo no se desarrollaba. Se preguntaron cuál de las tres vías era la implicada y hicieron el modelo sobre un ratón knockout para C5, vía común de las tres vías de complemento, y vieron que efectivamente no se desarrollaba daño renal. Cuando esto mismo lo realizaban en un ratón knockout para C4, vía lectinas, el modelo se desarrollaba al completo, es decir, las lectinas no eran las que estaban implicadas en la vasculitis ANCA. Y cuando lo hacían sobre un ratón knockout para factor B, de nuevo observaban que el desarrollo de la enfermedad no ocurría, es decir, que era la prueba evidente de que en la vasculitis ANCA era necesario la existencia de la vía alternativa del complemento para el desarrollo de la enfermedad. De hecho, También cada vez existían más dudas de si realmente esta vasculitis podía ser etiquetada de pauciinmune, porque aunque las inmunoglobulinas y el complemento no estaban en una presencia muy importante, sí que lo estaban. Aproximadamente un tercio de las biopsias renales podíamos encontrar inmunoglobulinas, en concreto IgM, y en muchas de ellas, en otro tercio, C3. Por tanto, no eran tan pauciinmunes como al principio podríamos haber pensado. De hecho, este es un estudio que hizo nuestro grupo en el que, utilizando técnicas de inmunohistoquímica para C3D, que es un factor concreto de la vía alternativa del complemento, observamos que el 50% de las muestras eran positivas para este C3D. Y en concreto, los pacientes que fueron positivas para esta tinción eran las formas más severas, las formas que debutaron con una función renal más comprometida, que requirieron al inicio un diálisis aguda en mayor porcentaje y que tuvieron una respuesta al tratamiento menor. De hecho, aquellos pacientes que tiñeron con C3D tuvieron una supervivencia renal significativamente peor que aquellos pacientes que no fueron positivos para esta tinción. También todos sabemos que los niveles de C3 son normales en la vasculitis SANCA. No es del todo cierto, aproximadamente entre un 8 y un 5% de la pacientes con vasculitis SANCA tienen hipocomplementemia. Pero aún aquellos que tienen complemento normal, aquellos que en el momento de actividad tenían unos niveles de C3 más bajos, en el tercil más bajo de la normalidad, al igual que ocurría con las tinciones, eran formas renales de debut más agresivo, eran formas que tenían una función renal menos preservada, que tenían una mayor necesidad de diálisis al diagnóstico y cuya respuesta al tratamiento fue significativamente más baja. Desde el punto de vista histológico, también tenían mayor número de glomérulos esclerosados y mayor porcentaje de fibrosis intersticial. Todavía no, aunque es evidente que es la vía alternativa del complemento la que está implicada en la vasculitis SANCA, la verdad es que a día de hoy no sabemos con exactitud cómo esta vía alternativa del complemento está disregulada para que colabore en el daño de la vasculitis ANCA. Sí se sabe, por ejemplo, que el C5A, que es parte ya terminal de la cascada del complemento, actúa al igual que en otras enfermedades, pero en la vasculitis SANCA también como citoquina quimiotáctica para células inflamatorias como los eosinófilos, los monocitos, las células T y en concreto en la vasculitis para el neutrófilo, al que activa para que sea dañado por los anticuerpos ANCAS. En modelos animales se ha observado que bien bloqueando el C5A por un anticuerpo o bien bloqueando su receptor, el modelo de vasculitis ANCA también se frenaba. El avacopan es un fármaco oral que es altamente selectivo para el receptor C5A. En los últimos años se habían hecho 2 ensayos clínicos fase 2 en el que el uso de avacopan, cuando se comparó con otro inmunosupresor, cuando se comparó a corticoides, mejoraba el control vasculítico de la enfermedad renal. En este contexto se diseñó el ensayo clínico AVOCATE, en el que los pacientes, 320 pacientes, fueron aleatorizados a recibir tratamiento de inducción con rituximab o ciclofosfamida seguido de azathioprina con prednisona durante solo 20 semanas frente a avacopan a dosis de 30 miligramos 2 veces al día durante 52 semanas. La serie o la cohorte de pacientes que fue tratada fueron pacientes, la mayor parte de ellos vasculitis de novo, aunque también se admitieron pacientes en recaída. Aproximadamente la mitad eran MPO y PR3, eran formas de vasculitis severa con un BVAS de 16. El 60% se trató con rituximab y aproximadamente un 35% con ciclofosfamida, la mayor parte intravenosa. La mayor parte de los pacientes, pero no todos, tenían afectación renal y se excluyeron pacientes con filtrado glomerular por debajo de 15 mililitros minuto. El evento primario fue BVAS 0 sin necesitar esteroides en las 4 semanas anteriores. y establecieron 2 puntos de análisis. A la semana 26, cuando los esteroides habían sido recientemente suspendidos, y a la semana 52, después de casi 32 semanas de haber suspendido los esteroides, pero haber mantenido el avacopan. A las 26 semanas, el tratamiento con avacopan no fue diferente a los tratados con esteroides, es decir, el tratamiento fue no inferior, mientras que a la semana 52 el tratamiento con avacopan fue superior a los tratados con esteroides. En cuanto a los eventos secundarios, que fue el cambio del filtrado glomerular y de microalbuminuria, el tratamiento con avacopan consiguió ganar 3.2 mililitros minuto más de filtrado glomerular que el estudio con esteroides. No sé si esto es clínicamente relevante o no, y no hubo diferencia en la microalbuminuria ni a las 26 ni a las 52 semanas. Otro punto importante del fármaco es que disminuía el riesgo de recaídas. Sin embargo, es muy importante tener en cuenta lo que he dicho previamente. Los pacientes tratados con prednisona fueron tratados con prednisona solo durante 20 semanas. No hay ninguna guía clínica en la que recomiende tratamiento de esteroides solo durante 20 semanas. Es verdad que ahora hay una tendencia a disminuir la carga de esteroides, pero estamos hablando de disminuir la carga de esteroides a partir del año, es decir, de las 53-54 semanas. Pero no hay ninguna guía terapéutica que contemple una retirada de prednisona tan rápida. Y por otro lado, hay estudios que demuestran que la retirada de prednisona de corticoides de forma precoz aumenta la probabilidad de recaída. Por tanto, el hecho de que el grupo tratado con solo 20 miligramos de prednisona tenga mayor número de recaídas entraba dentro de lo muy previsible antes de haber terminado el estudio. Por otro lado, aunque el estudio intenta comparar el avacopan libre de esteroides con una pauta con pocos esteroides, lo cierto es que tampoco fue real, puesto que la dosis en el grupo tratado, en el grupo de prednisona, la dosis que finalmente recibieron fue de 3.6 gramos, 3.600 miligramos, mientras que el grupo de avacopan no estuvo libre de esteroides, porque por las manifestaciones extrarrenales necesitaron esteroides y necesitaron aproximadamente la mitad, es decir, que en realidad el avacopan solamente redujo los esteroides 1.5 gramos en las 52 semanas de tratamiento. El receptor del C5A es un fármaco que bloquea el complemento, como hemos dicho, en su parte terminal. Es un fármaco muy prometedor, no solo para la vasculitis, sino también para otras enfermedades glomerulares. De hecho, me consta que hay ensayos clínicos en la glomerulopatía C3 que están intentando evaluar este nuevo fármaco, porque aunque este nuevo fármaco, al igual que el eculizumab, bloquea la rama final del complemento, al permitir que se siga formando el complejo de ataque de membrana a través de las lectinas y a través de la vía clásica, permite mantener el complemento como elemento inmunológico y por tanto no necesita la vacunación y no inmunodeprime al paciente tan intensamente como el eculizumab. Como dije previamente, aunque ya tenemos un fármaco que en la vía terminal nos podría ayudar en el tratamiento de la vasculitis, limitando el efecto de la vía alternativa del complemento, realmente no sabemos a día de hoy qué ocurre en la vía alternativa del complemento para que participe en el daño de la vasculitis ANCA. Como sabemos, en otras enfermedades como en el síndrome hemolítico urémico o en la glomerulopatía C3, en muchas ocasiones esa disregulación viene de la mano de alteraciones genéticas. Y por eso en este estudio que se ha presentado como comunicación oral en este congreso, se comparó distintos haplotipos y alelos de los principales factores reguladores de la vía alternativa del complemento con una población control de 180 pacientes que no tenían vasculitis y que tenían función renal preservada. Y se observó que los pacientes con el haplotipo H6 para el factor H tenían un riesgo de desarrollar vasculitis 3 veces mayor que la población general que no tenía que la población que no tiene este alelo. Asimismo, que no tenía este haplotipo, perdón. Asimismo, el alelo R del factor B también aumentó un 70% el desarrollo de vasculitis Cuando comparamos a los pacientes que teniendo vasculitis habían desarrollado formas más severas de las mismas, observamos, y esto se midió con un VAS más elevado, observamos que la presencia de la delección para la proteína relacionada con el factor H1 y 3 protegía el desarrollo de vasculitis. Esta no es una asociación que nos haya sorprendido. La delección de las proteínas relacionadas con el factor H1 y 3 es una delección relativamente frecuente en la población general y que ya se ha asociado también a la prevención de otras enfermedades como la IgA. Cuando analizamos los factores séricos, los medimos en situación de actividad y en situación de remisión, vimos de nuevo que aunque el C3 era normal en la mayoría de los pacientes en momentos de actividad, sus niveles fueron significativamente más bajos que cuando los pacientes entraron en remisión, y lo mismo ocurrió con el C4. Cuando comparamos el complejo de ataque de membrana, vimos que se estaba produciendo mucho complejo ataque de membrana en situación de actividad y que era significativamente más elevado que en situación de remisión. Al analizar los factores reguladores, el factor H, el factor B y la properdina, observamos que en situación de actividad los factores reguladores estaban disminuidos respecto a la situación de remisión, es decir, que su capacidad de regular en situación de actividad estaba disminuida. Asimismo, cuando comparamos los factores basales, los factores en momentos de actividad de los pacientes, según a los 12 meses alcanzaron o no remisión, vimos que aunque los factores reguladores estaban significativamente más bajos en momentos de actividad que en momentos de remisión, estos niveles eran aún más bajos en aquellos pacientes que a los 12 meses no alcanzaron remisión, es decir, que en los pacientes que no alcanzaron remisión clínica, la disregulación del complemento era aún más intensa. Dos palabras de las proteínas relacionadas con el factor H. Las proteínas relacionadas con el factor H son un error de duplicación del factor H, de tal forma que las proteínas reguladoras 1, 2, 3, 4 y 5 comparten dos dominios con el factor H. Esta similitud les hace mantener el reconocimiento de la superficie celular del factor H, pero no hacen su función de regulación, es decir, que son compiten con el factor H en su acción regulatoria. ¿Qué ocurre con estas proteínas relacionadas con el factor H en pacientes con vasculitis ANCA? Pues vemos cómo estos factores en situación de actividad están aumentados respecto a condición de remisión. Es decir, ocurre la tormenta perfecta. El factor H está disminuido, regula menos, y por el contrario el factor H1 related, el 2 y el 3 están aumentados, lo que impide aún más la regulación del factor H. Finalmente, hemos visto antes cómo la delección, los pacientes que tienen la delección están protegidos y de hecho tienen unos niveles de factor H significativamente más bajos que los pacientes que no tienen esta delección. Pero algo más debe existir, porque si comparamos a los pacientes según su situación genética, según el VAS, aquellos pacientes con formas más severas, con VAS mayor de 15, tienen unos niveles más altos en cada una de las dos situaciones que los pacientes con formas menos severas. Por tanto, y para terminar, la disregulación de la vía alternativa del complemento es un factor fundamental en el desarrollo de vasculitis ANCA. Yo creo que ya a día de hoy no hay ninguna duda sobre esto. Algunos haplotipos, el H6 en el factor H o algunos alelos como el alelo R en el factor B, confieren riesgo para el desarrollo de enfermedad. Algunos haplotipos como la delección para la proteína relacionada con el factor H3 y 5 se protegen de formas más severas ANCA, al igual que ocurre en el lupus o la glomerulonefritis IgA. El avacopan, que es un bloqueante específico del receptor 5A, es una nueva posibilidad terapéutica que creo que va a abrir muchas opciones en el futuro, sobre todo en pacientes con intolerancia a esteroides y o recaedores. El avacopan todavía no está aceptado por la FDA, y debe haber algún problema porque lleva ya algunos meses sin que la FDA le dé el aprobado definitivo. Habría que explorar en cualquier caso otras opciones terapéuticas que actúen de forma más individualizada, no bloqueando el final de la vía del complemento, sino que actúe donde está realmente el problema, que es en la parte de la vía alternativa del complemento. No me quiero extender más. Muchas gracias a todos por su atención. Estaré encantada de intentar contestar a las dudas que la charla haya podido despertar. No quiero quitar ni un minuto al doctor Jane y al doctor Pussy, que amablemente han querido estar en la interesantísima mesa de hoy. Muchas gracias a todos.
Hello, my name's David Jane, and I'm talking to you from Cambridge in the UK. And I'm going to briefly review the treatment of vasculitis. We currently use the 2012 Chapel Hill classification, which defined the anchor group containing MPA, GPA, and eGPA. And most clinical research into vasculitis is focused on these subgroups. Anchor vasculitis causes an increased mortality. This is survival of a Swedish population, and you can see on the left-hand graph the excess mortality compared to a healthy control group. When the patients are subdivided according to organ involvement, it's those with proteinase 3 or myeloperoxidase positive kidney involvement that dominate the adverse survival. So kidney disease is important. When we look at predictors of outcome for patients with nephritis, there have been several scores developed, which we summarized in this review. The Bairden classification, which is based on glomerular pathology, the Mayo Clinic classification, which included extraglomerular histological features, and then a classification from Hamburg in Germany, which also included kidney function. But the two take-homes are that it's serum creatinine at diagnosis and histological damage, whether glomerular or tubular, which dominate long-term outcome. So the principles of treatment, as I've said, is that kidney involvement is key in terms of mortality and end-stage renal failure outcomes. Early treatment initiation produces the best results, but the impact of treatment toxicity rivals that of the disease. Therefore, it is important to minimize diagnostic delay, and essentially, if you're a nephrologist, that means optimizing referral pathways. And then to best manage the toxicity of the therapies, especially steroids, which we think are the major modifiable cause of treatment toxicity. So we divide treatment into an induction period of 3 to 6 months, where patients receive high-dose steroids tapering down, and either treatment with cyclophosphamide or rituximab. And Professor Pusey will discuss plasma exchange in the next talk. Once the disease is controlled, we then have a remission maintenance period, which is aiming to prevent relapse. And this is of an undefined duration. Typically, patients induced with cyclophosphamide will receive an oral immunosuppressive, such as azathioprine, methotrexate, or mycophenolate, or they could receive rituximab maintenance. Whereas those who receive rituximab induction will typically either receive rituximab maintenance or just be observed off treatment, although there are some physicians that use oral immunosuppressives after rituximab, but that's not usually recommended. So turning to steroids, now the Pexovas trial was a global trial that assessed plasma exchange, but it addressed a separate question, which was steroid dosing, and patients were randomized into 2 dosing groups. All patients started at the equivalent of 1 milligram per kilogram per day. They either dropped rapidly or they dropped more slowly, such that there was a 50% difference in steroid exposure. There was no impact of steroid regimen on death or end-stage renal disease. But there was an impact of steroid regimen on infection, with significantly fewer infections in the reduced steroid regimen compared to the standard steroid regimen. We've also looked at steroid dosing in a separate trial, the Remission trial, which recruited patients just with relapsing disease. And here, patients could either be induced with 1 milligram per kilogram per day or 0.5 tapering. We found no impact of steroid dose on the risk of the treatment failing in this trial, regardless of whether the patients were being recruited with severe or non-severe disease. This was not a randomized study, but the implication is that for relapsing patients, you can afford to start with less steroid. Turning to the induction immunosuppressive, the MySite trial assessed mycophenolate mofetil, and although at 6 months found no major difference to cyclophosphamide, at 18 months there was an excess of relapses in those patients induced with mycophenolate, which was seen mainly in the PR3 anchor group. This leaves open the possibility that mycophenolate mofetil is an option for patients with MPO anchor disease without the most severe degree of renal failure, but this does require further testing. So rituximab has been the major innovation in the last 20 years of vasculitis therapy, and of course is now available generically, and the price has come down. It is an effective treatment. So this again looks at the Remission trial, which recruited about 190 patients with relapsing disease, and all patients received rituximab induction, and this was effective in 91% of patients in inducing stable remission. So this is a remarkably effective treatment, and it's definitely the preferred treatment for relapsing disease. Turning back to the Pexovas trial, we allowed physicians to choose between IV cyclophosphamide, oral cyclophosphamide, or rituximab in terms of their maintenance dose. And for the outcome of death or end-stage renal failure, there was really no difference in the cyclophosphamide groups whether patients received the reduced steroid or the standard steroid dose. But although not significant, there was a clear trend for the rituximab-induced patients to do less well with the reduced steroid dose. So the implication of this is that if you're not going to give cyclophosphamide, you're probably going to need to give more steroid. Just taking this a little bit further, there is an absence of trial data on rituximab steroid combination for severe nephritis, and this is a problem for nephrologists. There is a suspicion that rituximab is slower in onset of its benefit, and therefore a higher dose of steroid is likely to be required. And there's been quite a bit of interest in looking at the combination of rituximab with low-dose cyclophosphamide, and indeed this was tested in a European trial, Pexovas, some time ago now. Several centres in London and Ireland have taken this work with the combination therapy a little bit further, and they've driven down the steroids required. So older European studies typically use 6 grams total exposure within the first 6 months. The reduced dose Pexovas regimen uses about 3.5 grams. But using this combination, they've driven the steroid dose, total steroid exposure down to about 1.2 grams, and have shown really quite good efficacy here for reductions in BVAS and here in reductions in serum creatinine. And when compared to historic cohorts from the UVAS trials, mortality has been better and end-stage renal failure outcomes have been better. So there is interest in further developing this combination for patients with nephritis. So what about maintaining remission? So it's important for the clinician to have some understanding of risk assessment, because the type and duration of treatment is going to be influenced by what you think the risk of relapse is and what the consequences of relapse may be. So we know that various factors imply a higher relapse risk, such as the diagnosis of GPA, PR3 ANCA, persisting ANCA after induction, ear, nose and throat involvement, and previous relapse. These all code for a higher relapse risk. Similarly, we know that a diagnosis of MPA, the presence of MPO ANCA, worse kidney function, and no history of relapse codes for a lower risk of subsequent relapse. Now, I mentioned earlier that the duration of relapse prevention treatment or maintenance treatment is unknown. The Remain trial looked at 2 years versus 4 years of azathioprine and steroids after cyclophosphamide induction, and surprisingly found a big difference in terms of survival without relapse in favour of the continued group. And indeed, they also saw significant benefit in terms of end-stage renal disease for continued immunosuppression. And in this study, we did not find the ANCA subtype or the presence of ANCA at 18 months particularly predictive, and the dominant factor was continuing azathioprine and steroid. However, the other more recent trials are focused on rituximab, and we now have 2 trials showing that rituximab is better than azathioprine at preventing relapse. The main trial, which treated with 1 gram at 6 months, then 500 milligrams every subsequent 6 months for new patients, and the Retazarem trial, which recruited relapsing patients induced with rituximab and gave 1 gram every 4 months, so quite a high dose. And both trials show significantly fewer relapses with rituximab. The problem with rituximab, and there are several, is what happens when you stop. And what happens when you stop is you start seeing more relapses. So this is the last dose of rituximab in the Retazarem trial. And after about 6 months, when the rituximab effect has worn off, you can see that the relapses occur in both treatment groups. Now, the French study group have gone on to do a further study continuing rituximab out to 4 years, and no surprise that continuing rituximab reduces relapse rates. But rituximab has a high risk of causing secondary immunodeficiency, and it impairs vaccine responses. One factor that we think is relevant is the persistence of ANCA after rituximab. Approximately 50% of people remain ANCA positive after rituximab. And if you remain ANCA positive, your relapse risk, shown in the blue line here, is very much higher. So in some patients, you can use ANCA to help guide rituximab dosing, but on the whole, we've not found B cell counts to be useful, and we've stopped doing those. So to close this talk about treatment, I would like to emphasize the importance of the breadth of the disease burden. All we've really talked about is suppressing active disease and trying to reduce relapse. But it's very important in the longer term treatment of patients to manage the organ damage patients have suffered, and particularly to focus on comorbidities, that's severe infection, malignancy, cardiovascular and thromboembolic risk. And these events will affect well over 1/5 or 1/4 of our patients. There's also the issue of health resource, the long-term impairment of quality of life, trying to understand that and manage that better. And I have highlighted the issue of minimizing drug toxicity. So the disease burden from the patient perspective is multifaceted. So to summarize the current treatment, this is the 2016 EULAR, European Renal Association recommendations, and this simply summarizes what I've said in terms of induction therapy, remission, and then maintenance therapy. I would highlight the importance of defining refractory disease. In other words, if you're not getting where you want to get to, it's important to seek expert opinion or colleagues' opinion, reevaluate the diagnosis, and consider optimizing the treatment. And we do now have choices. We have cyclophosphamide or rituximab, so we have choices or the combination. Now, there is an update planned for 2022. This is not yet funded, but we have applied for money to update the recommendations, and this may include newer drugs such as avacopan. So I've stressed the importance of early diagnosis, the trends in therapy such as reducing steroid dosing, and we can now recommend the Pexovas reduced oral steroid regimen, the increased use of rituximab for both induction and maintenance, and some data to do with the rituximab cyclophosphamide combination. I've also stressed the importance of managing the risks of treatment and the risks of comorbidities, because after you've gained control of vasculitis, these are what are going to dominate the patient's outcome. I'd like to thank you for your attention and acknowledge many colleagues in Cambridge who've contributed data, colleagues in the European Vasculitis Society, particularly those from Spain and from Barcelona, and colleagues in North America and other parts of the world that have contributed data. Thank you for your attention.
Good afternoon. I would like to start by thanking the organisers for inviting me to this meeting, and it's a great shame that we can't meet in person. You have just heard about the treatment of vasculitis in general, and I've been asked to talk about plasmapheresis. Is it still indicated in ANCA-associated vasculitis? Those are some of my declarations. I think you are all familiar with the classification of systemic vasculitis by the Chapel Hill Consensus Conference, which divides diseases up according to the size of blood vessel involved and a series of short clinical definitions. ANCA-associated small vessel vasculitis was identified as a separate group of diseases, including microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. And as you know, kidney involvement is common in both MPA and GPA, less common in EGPA. There is now an increasing amount of evidence that ANCA are directly pathogenic in vasculitis. Clinical studies have shown ANCA are highly specific and sensitive for the diagnosis of vasculitis, and their levels generally correlate with disease activity and can predict relapse. Cell culture studies have shown that ANCA have pro-inflammatory effects on human neutrophils and monocytes, inducing the release of enzymes, cytokines, and other factors. And using animal models, we've been able to demonstrate passive transfer of vasculitis by anti-MPO antibodies, and also actively induce autoimmune vasculitis by immunization with MPO. So I think there's now considerable evidence that ANCA are directly pathogenic, and therefore their removal would appear to be a logical approach to treatment. Plasma exchange has a variety of effects, and in ANCA-associated vasculitis, the most important one probably is removal of the autoantibody, the ANCA, by plasma exchange. And plasma exchange removes about 70% of IgG by exchanging one plasma volume. However, also important might be in depletion of inflammatory mediators, such as coagulation factors and complement. And you will be aware of the importance of complement in pathogenesis of AAV. Now, the guidelines on the use of plasma exchange in AAV are rather out of date. And of course, they relate to the use of plasma exchange as additional treatment during induction therapy. So the EULAR ERA guidelines suggest plasma exchange is considered in the presence of rapidly progressive renal failure or pulmonary hemorrhage. The KDIGO guidelines were published back in 2012, but in a more recent KDIGO controversies conference, it was suggested that plasma exchange was considered in the presence of severe renal impairment and or diffuse crescents and in pulmonary hemorrhage. Of course, these guidelines were made before publication of the recent Pexovas study, and it will be interesting to see what the updated guidelines say. Plasma exchange has been around for the treatment of vasculitis for a long time, and Lockwood and colleagues from Hammersmith Hospital reported in The Lancet in 1977 9 patients with vasculitis and crescentic GN treated with a combination of prednisolone, cyclophosphamide, and plasma exchange. And all but one of these patients had a creatinine greater than 500. There was a rapid response in 5 patients, a slower response in 3, and no renal recovery in 1. And 4 patients came off dialysis. And at the time, that was a remarkable result. As a follow-on to that, we went on to perform a randomized trial of plasma exchange in focal necrotizing glomerulonephritis and vasculitis. And again, patients were treated with prednisolone and cyclophosphamide with or without the addition of plasma exchange. And you can see in this table of results that all of the patients did well in treatment and control groups with a creatinine less than 500, or indeed a creatinine of greater than 500, but not on dialysis. However, in the dialysis-dependent group, a higher number of patients recovered kidney function than in the control group, suggesting there was a benefit of plasma exchange in dialysis-dependent patients. There have been a number of other small studies since, but the next large study was the Mepex trial organized by the European Vasculitis Study Group. This was a randomized trial of plasma exchange against methylprednisolone for induction of patients with AAV and a creatinine of greater than 500 or on dialysis. Now, as you can see in these results, plasma exchange increased the rate of renal recovery. There were fewer patients with kidney failure in the plasma exchange group than in the methylprednisolone group. And patient survival and adverse events were similar. So this suggested benefit of plasma exchange in patients with severe kidney disease. However, on long-term follow-up of the Mepex group, when you look at the combined endpoint of kidney failure or death, you will see that long-term there was no significant benefit of plasma exchange compared with methylprednisolone. However, there was still a long-term benefit in terms of a lower incidence of kidney failure in the patients treated with plasma exchange. And these results really led to the development of the Pexovas study. So the Pexovas study was published last year. It was a large study of 700 patients with a GFR less than 50 or lung hemorrhage, or both. It was a factorial design where patients were randomized into plasma exchange or no plasma exchange, and then standard or reduced corticosteroid dosing. And you can see the results here in this left-hand slide, looking at a combined endpoint of death or end-stage kidney disease. There was no significant benefit of plasma exchange in the longer term. In the right-hand graph here, you can see that the standard dose glucocorticoids were not inferior to the reduced dose glucocorticoids. So both doses of glucocorticoids were very similar, suggesting that we should all adopt the lower dose glucocorticoids. However, when you look at the plasma exchange graph, there may in fact be some apparent short-term benefit of plasma exchange shown in this graph. And indeed, only about 20% of these patients were actually on dialysis. So any benefit in terms of kidney recovery might well be lost looking at the overall outcome of the group. An ongoing analysis of plasma exchange on both dialysis-dependent patients and on lung hemorrhage patients is still ongoing. We have not yet got the results of that. In the original paper, however, they did look at subgroup analysis. And you can see in this subgroup analysis that patients requiring dialysis or with a creatinine greater than 5.6 milligrams per deciliter showed a trend towards a benefit of plasma exchange, as indeed did patients with lung hemorrhage, shown here. So I think these two groups require further analysis. Since the Pexovas study has been published, there has been one meta-analysis, including those results. In this meta-analysis, it looked at randomized controlled trials of plasma exchange in AAV. And these were the studies concerned, shown on the left, including Pexovas. And it is shown here that plasma exchange significantly reduced the risk of end-stage kidney disease at 12 months. However, set against that, plasma exchange appeared to increase the risk of severe infections. So I think this latest meta-analysis, which does include Pexovas, confirms the benefit of plasma exchange in the recovery of kidney function. To get you up to date, this is a recent series from the Hammersmith, which has just been accepted for publication in Kidney International. We treated 64 patients with severe vasculitis, with a creatinine greater than 500, or with severe lung hemorrhage, about half of whom were actually on dialysis. And we used a treatment protocol involving rituximab, low-dose intravenous cyclophosphamide, with about 6 doses of 500 milligrams IV, similar to the Euro Lupus protocol, a rapid taper of oral prednisolone with no additional methylprednisolone, and 7 plasma exchanges, roughly. And you can see we had remarkably good results. There was recovery from dialysis in 67% of patients, and the end-stage kidney disease-free survival, that is the combined endpoint of surviving free of kidney disease, was 75% at 1 year, as shown in this graph. And in Mepex, remember, it was only about 50%. So we had a good long-term result there. And interestingly, when you look at kidney survival on the right-hand graph, those patients with a creatinine greater than 500, but not on dialysis, had a better long-term survival than those patients who presented on dialysis, although even they did quite well. And this shows it's perhaps not correct to lump these together in trials because these two groups do perform rather differently. There's also been a cohort study, a large study of nearly 250 patients with diffuse alveolar hemorrhage from Japan, and 43% of these were on ventilation. And within this cohort, they took 59 pairs of patients, propensity matched for disease severity and comorbidity, and looked whether with and without plasma exchange. And you will see that plasma exchange was associated with a lower in-hospital mortality, 36 versus 54%, but was not associated with any more infections. And mortality was predicted by age, which is not surprising, the need for mechanical ventilation, and by the lack of plasma exchange, suggesting that plasma exchange might be of benefit in lung hemorrhage, as well as in advanced kidney failure. Finally, what of patients who are double positive for both anti-GBM antibodies and ANCA? And you'll know that about 10% of ANCA patients have a GBM antibody, and about 40% of anti-GBM patients have an ANCA. So this quite commonly occurs together. And this is a European study organized from Hammersmith, looking at 41 single positive anti-GBM patients, 37 double positive patients, and over 500 vasculitis patients treated during the same period of time as controls. You can see in this left-hand graph, patient survival was very similar in all 3 groups. But here in this middle graph, you'll see that renal survival was much better in the vasculitis group, as you might expect. And renal survival was probably worse in the anti-GBM group and very similar in the double positive group. Although the double positive group did show a trend to a slightly better renal survival, and this might be because more of these double positive patients came off dialysis, 29% compared with 17% of the single positive anti-GBM patients. And we wonder whether this might be because in some patients, the renal pathology is dominated by ANCA disease rather than by anti-GBM disease. If you look at relapse in this right-hand graph, relapse in double positive patients was very similar to that in the AAV patients, but single positive anti-GBM patients did not relapse. So in these double positive patients, they tend to behave initially like anti-GBM disease, they require full treatment with plasma exchange, but in their long-term management, they behave like vasculitis, and so they require maintenance immunotherapy. So in conclusion, I think I've shown you that there is a strong rationale for the removal of ANCA because they have been shown to be pathogenic. Early studies show that plasma exchange improves renal recovery in severe AAV, including the quite large Mepex study. However, Pexovas shows that plasma exchange is not of long-term benefit in AAV more generally when you include all patients with a GFR less than 50. However, a subsequent meta-analysis does confirm benefit of plasma exchange in renal recovery. There have been promising results of a combination of rituximab and low-dose cyclophosphamide together with plasma exchange in AAV. And there has been a cohort study showing the benefit of plasma exchange in AAV with pulmonary hemorrhage. And finally, it's clear that plasma exchange is required for double positive patients. So I would suggest that until we get the results of the analysis of dialysis-dependent patients and lung hemorrhage patients from Pexovas, and until we see the publication of the recent meta-analysis, we should still consider plasma exchange in AAV patients with either severe renal disease or pulmonary hemorrhage. Thank you very much for your attention.
Okay, we're back, and now we'll start the discussion panel. We'll give this panel in English so that all our invited guests from the UK can understand all the questions, and we'll be translating all the questions from the audience. First of all, I'd like to thank all the speakers for such excellent presentations. And we have already many questions from the audience, but I wanted to start by asking both Dr. Jain and Dr. Pusey on the importance of the histological classification, or whether we should take it into consideration both in our induction treatments. Should we personalize treatment according to the classification, the histology in the kidney biopsy? And should we consider making plasma exchange according to the degree of sclerotic lesions or active lesions in our kidney biopsies?
No, David, do you want to start?
Well, why didn't you go first, Charles?
Okay. So I think it's very important to consider the histology in determining your treatment plan, because we should be moving towards individualizing treatment wherever possible. And clearly both the burden classification and the BRICS renal risk score do give you some idea about the likely outcome. So I think even though I think there's not enough data to define exactly how we should behave in terms of the renal histology, we clearly need to consider that in terms of our management plan for each patient.
So to pick up the question of plasma exchange, we did do a study following Mepex, looking at whether there were particular renal histologic features that would respond better to plasma exchange than others. And the short answer is that there weren't. And even in patients with the most adverse looking biopsies, there was potential for renal recovery, or greater potential for renal recovery with plasma exchange. And just to extend Charles's comments on the evidence, Mike Walsh has conducted a meta-analysis looking at the endpoint of end-stage renal disease at 12 months. And there is a benefit for plasma exchange, convincing benefit for plasma exchange when you add the Pexovas data into the previous data. And remarkably, the Pexovas data is quite in line, in fact, with the Mepex data when you look at it in that way. So there is an independent recommendation statement that has been prepared, which will recommend plasma exchange for serum creatinines over 500. It's just that the plasma exchange has less to offer patients with lower levels of renal function because their end-stage renal disease risk is much lower.
Exactly. And I think the issue with the histology not always predicting outcome is that, as you know, the systemic vasculitis is a focal lesion. So sometimes if you get a rather small biopsy, you may not get a representative picture of the whole kidney. So I would like to think that if you had active inflammation with a lot of presence, that would be one you'd try the most aggressive treatment for. But that's not always the case because, as David said, sometimes you can get a rather scarred-looking biopsy and the patient still responds. And that, I think, is because it's a focal disease.
The other dimension that you may not have considered, and this is more of a discussion now, is the performance of a second biopsy or a repeat biopsy. If you have a diagnostic biopsy that shows a good capacity for renal recovery, so you've got crescentic changes, fresh crescents, and your patient is not getting better in the way that you think they should in terms of their GFR recovery, then those sorts of patients were tempted to do a biopsy at 6 to 8 weeks to see whether our initial evaluation was correct and perhaps whether this patient is now becoming, if they're still on dialysis, is now hopeless to continue with aggressive treatment. But Charles, I'm interested in your view about the repeat biopsy.
Yeah, I agree totally. I think where you can do it safely, a repeat biopsy can be very helpful. And as you all know in this audience, a second biopsy in lupus has been shown to be probably of more benefit than the first in terms of how the patient will respond. And we may find a similar finding in vasculitis. So I'd certainly recommend a second biopsy where you feel you can do it safely, particularly if the patient is not behaving as you thought they would.
Thank you. The next question is for Dr. Jain and Dr. Gemma Fernandez. It's about, do you think it is worth it to request a genetic complement test from all of our patients?
Maybe I'll let Dr. Fernandez answer that one first.
Okay, I can repeat. Do you think that in clinical practice we should request a complement test, a genetic complement test?
Today, in my opinion, the answer would be no. When you order a genetic test in hemolytic uremic syndrome, it's probably because it depends on the findings, your clinical practice would change. If you find a disorder in factor 8, for example, you can't remove eculizumab treatment. And otherwise, if you find a disorder in MCP or you don't find any disorder, maybe you can read out eculizumab after the acute episode. However, in ANCA vasculitis, we don't have this kind of information, and therefore genetic test information will not have clinical effects. So at least so far, we can't recommend test genetic in ANCA vasculitis. We need more information, and the results that I have been presented are very, very preliminary.
Yeah, I would agree. I think we're really just at the beginning of our understanding about complement in ANCA vasculitis. There have been some quite old candidate studies of complement C3 polymorphisms, which have shown weak associations with ANCA vasculitis, but in the genome-wide association surveys, there have been no hits near complement loci. I would say, though, there's a small minority of ANCA vasculitis patients who present with hypocomplementemia, low C3 or C4. And it would certainly be interesting, perhaps at the moment, from a research point of view, to try to understand whether that's reflecting some form of monogenic polymorphism.
Thank you. Next question from the audience is directed to Dr. Jain. They ask you whether we should remove the maintenance treatment with azathioprine and PR-free ANCA vasculitis with persistent positive anti-PR3 after 3 years from onset and with clinical remission with normal kidney function, but with intermittent microscopic hematuria. What's your opinion? Could it be a residual lesion or could it be persistent extracapillary proliferation?
Okay, so you're asking two questions. One question is, what should be the duration of maintenance therapy in a patient who's persistently PR3 ANCA positive? And the other question really is, what is the significance of intermittent hematuria during the remission phase? I think with respect to the first question, the point about remission maintenance treatment is if you reduce the therapy, you increase the relapse risk. Now, there are some patients in you whom you're happy to do that because you know the consequences of relapse will be modest, and maybe they are going to be very adherent with testing, and you're confident you will pick up a relapse quickly. And there'll be other patients in whom you're very concerned that should a relapse occur. So this is not a simple answer for all patients. I think the key point for the physician is stopping the drug increases the relapse risk. You then need to factor that into your general management advice for the patient. But what I can say is that with high levels of ANCA in whom we safely stop azathioprine, and the ANCA remains high and they don't relapse, but we watch them carefully. And I would not continue azathioprine for more than, well, certainly not more than 3 years in a patient who has achieved a stable remission and doesn't have a history of relapse, even if the ANCA is positive. I would remove it slowly and I would observe carefully. Now, with respect to the second question, and this was about the microscopic hematuria, renal relapse is the sort of relapse we worry about because renal relapse is associated with an increased risk of end-stage renal disease and of death. So, influenced by what your GFR is. If you've got a patient with a normal GFR, you're a little bit more relaxed. But there's quite a debate at the moment as to what the significance of urinary abnormalities mean. You may be aware there's a new urine biomarker called CD163, which associates with active renal vasculitis. When that test becomes available, that's the sort of patient you might want to test that in. I think I would be watching this patient carefully. I'd be considering repeat biopsy to see whether there were any active lesions. But if everything was quiet, the persistence of the low-level hematuria would not stop me from withdrawing the treatment. I would still withdraw the treatment if the patient is stable, but I would watch closely.
Can I add? I think I agree with David. In this sort of patient, you'd watch them very closely and you'd consider a repeat kidney biopsy before changing their treatment. Because obviously that you can get continued microscopic hematuria either from existing damage or also from a fresh bout of inflammation. So you should take it seriously and possibly consider a repeat biopsy in those cases.
Just pursuing this debate about the urine, around about 50% of patients have persisting urinary abnormalities, blood or protein or both. And we've never really known how to deal with this in a patient who has a stable GFR. But one of the observations in the avacopan studies is that the hematuria and proteinuria are going away or are going to much lower levels than they have with conventional therapy. And this is causing us to reevaluate perhaps what the significance of these urinary abnormalities may be. I mean, it's suggesting we need to perhaps take more notice of them.
I think, again, as in patients with lupus, sometimes they can be clinically inactive but have an active kidney biopsy. And we're suspecting we may be seeing the same in vasculitis. Maybe some patients that otherwise appear to be in remission, but actually they've got some continuing low-grade kidney inflammation. So I agree with David.
And one of the things that you do see, which I never thought was true, was a relapse, a renal relapse in a patient with a normal urine. But we have patients in whom the reason for biopsy is a declining GFR, which is unexplained, and the biopsy shows active lesions. So you mustn't be too strongly guided by the urine.
May I have a question? Sorry, may I have a question for Dr. Pusey? Dr. Pusey, how often do you recommend a kidney biopsy? Each time you suspect a renal relapse, or each time that appears some kind of alteration in renal function after achieved renal remission, or how often?
I think if a patient were to have a clinical relapse and their kidney function is not particularly bad, and you know they've had a relapse from other clinical features, then I would probably get on and treat and probably would not biopsy. But I would certainly biopsy if I was suspicious that there may be some change in kidney function, say the ANCA's still positive, but they weren't showing obvious signs of vasculitis relapse in other organs, I would certainly consider a biopsy. And as we said earlier, if they've been treated with the optimum type of treatment and they're not getting better by 3 months, for example, then I'd consider an earlier biopsy then. But I wouldn't biopsy someone with an obvious relapse that I was going to treat anyway, because clearly you want to eliminate that risk if it's not going to change your decision very much.
Okay.
Maybe in the past question, I think we should be much more careful in relapses in vasculitis because the capacity of an elderly kidney to recover from a kidney flare is much less than in young kidney, for example, in lupus nephritis. In avacopan, for example, the average of glomerular filtration that the patient recovered was around 5-7 milliliters per minute. So when the patient relapses, the amount of glomerular filtration that the patient lost is very, very important in ANCA vasculitis. So the price to pay in a relapse in ANCA vasculitis patient is higher than in lupus or in other disease, renal disease, because I think the difference is the age between the patient. In ANCA vasculitis, the patient used to be very old, and the very old kidney recover very bad.
Yeah, there are studies, as you know, showing a fall in GFR with each renal relapse. And as David mentioned earlier, renal relapse is associated with development of end-stage kidney disease. So you bear that in mind when you're considering your maintenance strategy in an individual patient. If they're an elderly patient with poor kidney function, you really don't want them to relapse. You treat accordingly.
The next question is for Eva Rodriguez, and I speak in Spanish for this question. The question is from the doctora Ana Jarque, que pregunta si en España existen laboratorios de referencia para analizar de forma estándar los ANCAs con especificidad IgA e IgM o los nuevos marcadores urinarios, y si deberíamos pedirlos en casos de que los ANCAs IgG fueran negativos. Y la tercera pregunta dentro de esta es ¿cómo recomiendas seguir estos pacientes ANCA negativos?
Thank you, Elena. As far as I know, there's no lab in our country who tested routinely anti-lambda tube or ANCA IgA or IgM, but there are a lot of ELISA kits available commercial. And in our lab, we were talking to buy first the ELISA kits for ANCA anti-AGA and AGM, and we test all our retrospective cohort from ANCA vasculitis negative patients. It's the first step in our study, and after that, we probably buy this. We don't know sure for that anti-lambda 2 ELISA kit for test all of these people. There's no biomarkers in clinical practice routinely. Actually, we need to wait for the results for the MCP1 or CD1 173, which seems they are the most promising of them. And actually, we are these patients we need to follow with the same, with clinical symptoms, with hematuria and creatinine and serum creatinine. I hope Dr. Jarque understands me.
Thank you very much. Next question is for the 4 speakers from the audience. Now, avacopan has been demonstrated to be effective in reducing the steroid dose. So could it also be effective in treating refractory cases? And in refractory cases, should we include also plasma exchange in cases of patients who didn't respond to cyclophosphamide nor rituximab?
This question is for Professor Jane, of course.
Yeah.
It's not directed to
maybe,
anyone, so-
Charles, you could answer about the plasma exchange for refractory disease first, and then I'll talk about avacopan.
I think there's no firm evidence for it, but many of us have clinical experience that in a patient who is not doing well with conventional therapy, the addition of plasma exchange sometimes appears to cause improvement. We have seen this in patients both with lung hemorrhage and with kidney disease. But I can't, as far as I know, David may know better, but as far as I know, there's no controlled trials looking at this. But my clinical impression is there will be some cases where if they have not responded to optimal therapy, and particularly if you're trying to avoid poisoning them with high doses of steroids or other drugs, then plasma exchange is a reasonable alternative to try in those patients.
With avacopan, at the moment, we do not have experience in refractory disease. The majority of patients studied in the trials to date have been new onset patients, a small number of relapsing patients. But if it has efficacy in vasculitis, which we think it does, then we will obviously look at refractory disease patients very quickly. I mean, it's interesting to comment on how drug development occurs, and rituximab, which essentially was developed by us, by clinicians, was first used in refractory disease, and we had a lot of experience in refractory disease. And then it's only subsequently been tested and used in newer patients when the trials were completed. Avacopan is doing the reverse. To me, the most exciting part of the avacopan story relates to the kidney and to renal recovery. And in the Advocate trial, we did not recruit the most severe patients, the ones Charles was talking about with respect to plasma exchange. And to me, one of the trials that I'd like to propose would be a trial of those patients presenting dialysis dependent or with high serum creatinines, and perhaps not just ANCA, but other causes of crescentic GN as well, because although the company have developed this drug as an alternative to steroids, it clearly has additional benefit over and above steroid.
Thank you. The next question is all for the four respondents, and is: what is your recommendation and your usual practice regarding vaccination for COVID-19 in patients with vasculitis receiving rituximab as maintenance treatment?
David, do you want to?
So in fact, this morning I was working on a recommendation statement that is being developed by the European Renal Association and by UVAS, the European Vasculitis Society. But this is a big problem. And there's been some recent publications showing that if you don't have circulating B cells, you're unlikely to mount a decent antibody response. Interestingly, if you don't have, or if you have low circulating CD4 positive T cells, you're also unlikely to mount an antibody response. But rituximab treated patients do seem to be mounting T cell responses, the same as with healthy individuals. So we do not yet have the data on how much less effective vaccination is in terms of clinical events for COVID-19 in rituximab treated patients versus those not rituximab treated patients who've been vaccinated. But our current advice, and this is purely pragmatic, is to immunize 4 to 6 weeks prior to rituximab. And we are now trying to avoid using fixed interval repeat dose rituximab, which is what we've been doing for 10 or 15 years. And we're trying to personalize the repeat dose rituximab to increase the interval as far as possible to give the patients the opportunity for a B cell return before further immunization.
A couple of weeks ago, a paper about a new CD20 that is used in a neurological disorder, not in a nephrological or hematological disorder, that they proved that maybe the humoral response after the vaccines in anti-CD20 patients is very bad, but cellular response is complete maintained. So they propose that maybe the response to the vaccine is not so bad that we, at least initially, we can think. And maybe the cellular response is hiding or try to do the best.
We have found the same thing. So rituximab definitely reduces the antibody response, but doesn't seem to affect the T cell response. But of course, we don't know to what extent either antibody or T cells protects them clinically from the infection. So at the moment, it's not clear to me the relevance of that. But certainly, we would try and avoid using rituximab if possible. We would delay it if it could be delayed. But clearly, if they need it urgently for acute disease, we would get on and give it. But we would, like David, we would try and delay it or spread it out, spread the dosing out if we could at this time. And we try and immunize before we give it, because we know the response is not good afterwards.
Thank you very much. Thank you very much. I'm afraid our time's up. And I'm very pleased to have seen all your excellent presentation. It has been a real pleasure to be with you in such an excellent discussion. I hope we can have both of you next time in person here in Spain. And thank you very much. I'm afraid there are many questions left from the audience that there wasn't time enough to ask, but we'll leave it to some other time. Thank you very much.
Thank you. Bye-bye.
Thank you very much.
Bye.
I hope we can join you again. Thank you.
Bye.
Thank
Bye.
Thank you. Bye.
Bye.